let me take you on a mental trip. So I hope. Okay. So imagine you are the facility in charge in any healthy facility or healthy center in Malawi. And then there is a broken door or there is indeed a light bulb that needs fixing. And then you call the district for them to fix. And they would incur some indirect costs. But if you had the funds, you would incur relatively lower costs if you were to, say, procure the bulb at the facility, correct? Is that right? Good. So the DFF comes in to solve some of those issues. So now, okay, that's the outline. As a matter of the background, we might be aware that primary health facilities play a very critical role in delivering primary health care across the rural populations in Malawi. And unfortunately, they perform or they work under a very constrained environment. For instance, they have no dedicated funding. They also have no budgets, and indeed, they have limited autonomy. And community participation in the financial management activities of the facility is very limited. So the Ministry of Health, in collaboration with development partners, they piloted the DFF, direct facility financing, in order to counter these challenges. So this, the pilot was conducted in Rumphi District across 15 facilities, and that was in the financial year 2023-24. And the key interventions during the pilot included, one, the direct transfer of funds, which range between 1 million to 2 million per facility, and also reconstitution and capacitation of the health facility management committees, the HCMCs, so that they should be able to participate in the public financial management activities of the facility. Now, this study is particularly just a subset of a broader study that we conducted. So particularly in this study, we wanted to empirically assess the implementation of the DFF pilot in order to determine its overall performance. And in so doing, we aimed to extract some key lessons that would then help in the national scale-up of the same. So as for the empirical strategy that we employed, firstly, in terms of the design, so it was an exploratory qualitative research design. And in terms of the analysis, we use we use deductive content analysis, I think for the reason that will be made plain in the next slide. And for the sampling, we use purposive sampling. So we sampled all the 15 participating facilities. And at each facility, we had key informal interviews with the facility in charge, as well as the focus group discussions with the members of the HMCs. And at the district level, we had key informal interviews with the DHMT, and at national level, we had key informal interviews with the DFF task force members. So the performance of the DFF pilot was assessed through the lens of the OECD DAC evaluation criteria. So with this criteria, basically what we looked at is we posed the question to say, is the objective of the DFF relevant? In other words, are the objectives of the DFF aligned with the needs and priorities of the facilities or the catchment population? And then next, we assess the extent to which the implementation of the DFF was actually effective in achieving its set objectives or results. And the next, efficiency, whether implementation of the activities conducted in an efficient manner. And then lastly, the extent or likelihood to which the program or the results thereto could be sustained in the long term. All right, so before we dive into the key results, just to, I want you to appreciate the demographics as well as the profile of the facility. So to your left rather, it's a graph showing the prioritization or the expenditures or the DFF expenditures across the facilities. So you would see that prioritization or priority areas varied across the facilities, but then you would appreciate that minor maintenance or construction was a universal need across the facilities, followed by office supplies as well as wash facilities. And with regards to the participants, three quarters of the participants were male, and they had 50% of them had certificate, at least a certificate, and then over 50, slight majority had worked at the facility for less than 5 years. All right, so now let's dive into the results. So with regards to relevance, the majority of the participants indicated that the objectives of the DFF pilot were highly aligned with their priorities and needs. And indeed, you would see that some of the facilities constructed, say, toilets, some bought batteries to put in the solar panels, and indeed some facilities used for various reasons. And we also paused the extent to which the design was perceived to be right for the function. So now, by and large, the design was well received because in their perspective, it increased their flexibility to address their local needs. And most of the facilities cited how that the design was perceived to be correct or right, in the sense that, for instance, one of the key informants indicated that the model combined both the facility management as well as the communities. Now, with regards to effectiveness, the findings indicate that the DFF was highly effective the pilot actually was highly effective in achieving its set objectives. And some of the key cited things included perceived increase or enhancement in terms of quality of care. And also some indicated that, for instance, because they had bought, say, batteries to use in the solar panel, so they could provide services even in extended hours, at odd hours, say at night. So that improved access to services. And there were also some other positive externalities. For instance, some of the facilities indicated that because they had used the funds efficiently and because of their transparency, because these facilities were posting all the budgets and expenditures on the notice board, so that led to other partners coming into the facility and then initiate their own projects. For instance, UNICEF initiated a wash project at one of the facilities. So there were other key barriers as well as facilitators to achieving these objectives. For instance, the trainings were cited as one of the facilitators, so there were those key facilitators. And in terms of the barriers included inadequacy of the funds, late disbursement of the funds, as well as weak monitoring and evaluation systems across the facilities. And with regards to efficiency, the program or the DFF pilot was perceived as highly efficient, and the efficiency varied across the facilities, with facilities that had prior experience in handling funds being more efficient than those that handled funds for the very first time. And some of the key strategies that the facilities employed in order to enhance efficiency was, for instance, bulk purchasing or procurement in order to leverage economies of scale. And indeed, some facilities involved local artisans. And there was also a high level of community for co-financing. The communities provided, say, sorry, I'm running out of breath because my time is out. Yeah, so the facilities, so some of the people could provide, say, sand or bricks for free. And even, indeed, some provided labor services for free. Okay, so sustainability. In terms of sustainability, the DFF, the likelihood that the DFF would be more sustainable is very high because there is high or strong political will, even within parliamentary as well as policy forums. And also the DFF is highly institutionalized as well as there is high ownership. So if you're gonna go home with one message, it should be the DFF is a viable health financing mechanism that can be leveraged to enhance facility autonomy, improve service delivery, and as well as build community ownership. The key recommendations that we advance, first, with regards to relevance, there is a need to regularly update eligible expenditure categories in order for the DFF to be responsive to the facility needs. Secondly, with regards to effectiveness, there is a need to, in as much as the DFF scale-up is warranted, yes, in as much as the DFF scale-up is warranted, but then it should take a staggered approach with initial investments in capacity building as well as monitoring systems. And there is a need to link some of the disbursement to facility performance. And finally, there is a need to develop a resource allocation formula that should guide the disbursement of the funds. These two highlighted in red, those have already been adopted by the ministry. As we are saying, the DFF is now in over 17 districts. And with regards to efficiency, there is a need to provide targeted training in financial management as well as procurement to SMCs as well as facility staff. And introduce DFF mobile money across the facilities. And finally, with sustainability, there is a need to strengthen community co-financing mechanisms and have these institutionalized in the facility planning as well as the DIP. And finally, there's a need to institutionalize continuous capacity building across the facilities. Thank you very much. We acknowledge our collaborators.